The presence of neck pain with headache doesn't automatically mean it's a cervical musculoskeletal disorder. 60% of people with migraines or tension-type headaches with neck pain, the neck function we've found to be normal.
Okay, welcome to the Hands-On, Hands-Off podcast. And this is brought to you by AAOMPT. And today we're excited to host our second of a four-part series or 4 episodes in collaboration with IFOMPT. So over this series, we intend to bring you conversations with internationally recognized leaders in orthopedic manual physical therapy. And I'm going to turn it over to Michael.
Thank you, Amy. Hi, everyone. My name is Michael Boney. I am the co-chair of the IFOMPT Learning and Professional Development Task Force, and also an associate professor at York University in Canada. Very happy to be joining Amy McDevitt, the AAOMPT member at large, and also associate professor at the University of Colorado in the United States. So just a little bit about IFOMPT. IFOMPT represents manual and musculoskeletal physical therapists around the world, and attempts to set up educational standards and clinical standards that are driven by the available scientific and clinical evidence. And you can learn more about IFOMPT at ifompt.org as well, and check out some of the Learning Zone webinars and educational resources that are available there. And today, together, we are thrilled to welcome 2 guests to help us better understand the science behind headaches and neck pain, Dr. Gwen Jull and Dr. Zhiqi Liang. So welcome to you both. And I'm going to pass it over to Amy to introduce Dr. Gwen Jull.
So Dr. Gwen Jull is an emeritus professor in physiotherapy at the University of Queensland, Australia. She is a specialist musculoskeletal physiotherapist and fellow of the Australian College of Physiotherapists. Her career has combined teaching, research, and clinical practice. Her research has principally been concerned with the diagnosis and management of idiopathic neck pain, cervicogenic headache, and whiplash-associated disorders, and quantifying the dysfunction in the cervical motor system as a basis for research-informed therapeutic exercise for the rehabilitation of neck disorders. Gwen has taught extensively, nationally, internationally, has published over 300 peer-reviewed articles, 40 book chapters, 3 textbooks, as well as editing the 3rd and 4th edition of Greaves' Modern Manual Therapy, now called Musculoskeletal Physiotherapy.
And I have this distinct pleasure of introducing Dr. Zhiqi Liang, who is a specialist musculoskeletal physiotherapist, as awarded by the Australian College of Physiotherapists, and lecturer in physiotherapy at the University of Queensland. Her research is on neck pain and headaches, especially migraine, for which she's received IFOMPT's David Lamb Memorial Award. She was a guest editor for the journal Musculoskeletal Science and Practice, which was a special issue on headache and neck pain, and is also the founding member of the Special Interest Group for Physiotherapists within the International Headache Society. Zhiqi also maintains an active clinical role in managing patients with headache at the university's physiotherapy headache clinic.
So we are so privileged and honored to have this esteemed group of experts join us today to help us explore neck pain and really more specifically the management of individuals with migraine-associated neck pain. So I think we're going to go ahead and dive in. And I'm going to ask a question that I would love for both of you to manage here. So across your careers, I know some of the work that you've been doing with NAHRU has really shaped how we think about neck pain and headache, from defining cervicogenic headache to now exploring migraine and sensitization. So what do you see as the most important shift in clinical thinking over that time? And I think I'll start with Gwen first, and then we'll go to Zhiqi to kind of piggyback on that answer.
Yes, thanks, Amy, and thanks for the introductions, and certainly a pleasure to be here. I might call it an advance over time, and I think probably from my perspective, especially in relation to cervicogenic headache, has been that we have a validated set of physical criteria that we can diagnose a cervical musculoskeletal disorder, which is underpinning cervicogenic headache. And if I'm allowed, I might do a little bit of history because it did take time to develop. And I mean, we've known for ages that the neck can cause a referred pain into the head. But it really wasn't until the 1960s that it was actually proven that cervicogenic headache was related to a joint disorder. And then we saw furthermore the development by Shorstad, where he did the criteria, and the most important diagnostic element was that you did a joint block to eliminate the headache. But the physical criteria in Shorstad's and even the International Headache Society today are still relatively general. And we saw it as an opportunity to really sort of develop them. We were doing, well, first of all, our early research showed that manual examination could quite accurately depict a painful zygapophyseal joint, and that was shown against diagnostic blocks. We were investigating motor control in the neck, and we were able to show that cervicogenic headache was associated with dysfunction in the muscles. And so the next study really put it all together. And so we looked at a whole musculoskeletal screen to see what could identify cervicogenic headache against migraine and tension type headache. And that's where it came out that the combination of a joint disorder plus a movement disorder plus a muscle disorder characterised collectively cervicogenic headache, and that distinguished them from tension type headache and migraine. So we had that set of criteria, and which sounds good, but we shouldn't really be terribly surprised about it because that's a typical musculoskeletal disorder. So you don't just get one thing going wrong in the musculoskeletal system. So it was that group. And then there was really good validating research done by Scott Getzoin from Chicago. I hope you know his paper, because that was very important, because he validated that group of musculoskeletal signs again against double-blind diagnostic blocks. So we have a validated set of criteria, and I think that's been extraordinarily important because it not only helps us diagnose cervicogenic headache, but it actually also helps us, and I'm sure Zhiqi will talk about, helps us to identify cervical musculoskeletal dysfunction in other forms of headache as well. So my thoughts are on that diagnostic triage of signs.
Yeah, and I appreciate you clarifying that, because I think it's important, as physios, to be able to have the ability to identify those and not just rely on our MD, counterparts to sometimes, make that diagnosis. So I think that's quite liberating.
Yeah, and certainly I've worked with neurologists who basically used to send patients to me for the express purpose, because they couldn't differentiate whether there was a cervical component or not. So they'd refer them for the distinct thing of me doing a differential diagnosis of the neck's role, basically.
Yeah. I thank you for that. And Zhiqi, what would you like to add to that in terms of some of these more critical shifts in our thinking clinically over time?
So Gwen talks about how we've known for a long time that the neck can refer pain into the head as headache. So the opposite is also true. I think the most latest recognition, again, we've known it for a long time that because of a trigeminal cervical nucleus, pain from the head can be referred into the neck as well. It goes both ways. But I think it's only more recently that there's been more research and recognition that, in some headache forms, especially primary headache, the neck pain can actually be coming from the headache instead of coming from the neck. And that's where that diagnostic criteria that Gwen talked about is so useful now, because that really helps us distinguish whether the neck pain is coming from the neck or is it actually being referred from the headache.
Yeah, and I think Michael has a similar question, but a little bit different, and I'll let him kind of go in that direction.
Mm-hmm.
Yeah, thank you. So it's interesting that you're talking about diagnosis, and there's so much overlap between symptoms with respect to headache and migraine related to neck versus related to head. So Zhiqi, it's very interesting that you say it could kind of work bilaterally through that trigeminal cervical nucleus, because there is so much overlap, especially between neck pain and the cervicogenic headache and migraine. Do you see these then as truly distinct conditions or more of a spectrum? And maybe Zhiqi will defer to you to answer first and then invite Gwen to.
Well, that's a great question, Michael, because I think there's some confusion out there for some clinicians. This is definitely distinct, right? Cervicogenic headache is a secondary headache, is referred from the neck. Migraine is a primary headache. The pathophysiology is entirely different. It's a neurological condition. It's a brain disorder. It's a sensory processing disorder within the brain. So although the both conditions can coexist sometimes, but they are definitely separate. So the challenge is working out whether someone has one or the other, or they have both, and if so, are they contributing to each other? So that's the real challenge for clinicians.
Yeah, that definitely is a challenge to try to differentiate the two, because there's so much overlap there as well. Gwen, would you like to add to that, or?
No, just really agree that they are quite distinct disorders. And as you said, there's overlap and people can have mixed headaches. So it's not a simple picture, but to me, they are very distinct, different headache forms. People talked about a continuum, or they have talked about a continuum for a long, long time. But I think mainly now that's been discarded, because they used to talk about a continuum of tension type headache and migraine and that sort of thing. But now that they're looking more neurophysiologically at the different headache forms, they're finding quite distinct differences between the different headaches.
You've certainly seen patients who've only got cervicogenic headache. It's very clear. Right. And you've seen the ones who've only got migraine. It's very distinct. And then you've got the ones in the middle who are a bit more challenging because they have probably a bit of both. And those are the ones that you really got to work out. Is it more cervicogenic headache with minor migraine-like features, but it's still more cervicogenic headache? Or is this really migraine, and does it have any cervical involvement at all?
Yeah. And so I guess speaking to that, Zhiqi, in order to kind of boil it down for the average clinician, I think, I think the clinical practice guidelines, for example, do a nice job of describing how to identify the cervicogenic headache. But what are some of those other maybe clinical findings that give you confidence that you're dealing with maybe a cervicogenic headache rather than a migraine or a tension type? How do we kind of help the clinician sort that out a little bit?
Gwen can add on to this after I've discussed some of this, but I think, in the patient interview, when you start asking and listening to the patient about what they're describing about a headache, you can start to see differences, right? If it's more cervicogenic, they'll describe this very mechanical neck-related pattern where it's things to do with the neck that's stirring up their headache, Whereas with migraine, they might describe that, but then they will also describe perhaps other triggers, migraine-related triggers like menstruation, environmental stimuli like, being in the sun, being dehydrated, eating certain foods. And they will also describe other symptoms that are not as typical in cervicogenic headache, like the photophobia, nausea, vomiting, intolerance to physical activity. So a distinct additional set of symptoms that will make you think about this is actually more looking like migraine rather than cervicogenic headache. And then when it comes to the physical examination, as Gwen mentioned before, if it is a cervical disorder, a cervicogenic headache, then we really are expecting to find those impairments, those group of impairments across muscle, articular, and movement domains that typically we find in all other musculoskeletal disorders.
Actually, I might use the word comparability, that you've got to find signs that are comparable to whichever headache it is. And even when we start to think cervicogenic headache, as you were saying, Michael, there's overlap. Even with cervicogenic headache, they can complain of photophobia or phonophobia, etc. But the intensity compared to that in a migraine patient is much, much less. And when we're looking at and Shortstad described all that at the beginning. So there's multiple symptoms that overlap, but I think the word to keep in your head or keep in your mind is comparability. So it's comparability in the intensity of different symptoms. And then also when you're doing an examination of the neck, if people are complaining of a 8 out of 10 headache, and yet your joint signs, they've maybe got a 2 out of 10 pain, minor stiffness, etc. It doesn't make sense, and then, range of movement might be pretty well normal and their muscle function is relatively normal. Joint signs are not great. It's just not adding up. And I think you've got to keep adding up all the different components of your examination in the differential diagnosis. Comparability.
Yeah. Go ahead, Amy.
Oh, I was just going to ask, how much weight do you put in location? I think many of us clinically are looking for this ram's horn presentation, and it's almost like a peripheralization, centralization phenomena if we're maybe challenging the various articular facets. But how much clout do you put in location as a differentiating factor for you?
None.
Okay, that's good.
Interesting.
Well, there's a lovely study by a fellow called Cooper. And instead of irritating something and then mapping where the area of pain was, what he did was he had people with neck pain and headache and neck pain, etc. And then he did joint blocks and he mapped where they got relief. Okay, so they were genuine patients with genuine pain pictures, and he mapped the areas of relief. And when you look at that map, whether it's an O1, well, they didn't do O1, but whether it's a C1, 2, C2, 3, etc., they had massive overlapping areas of pain. And the other interesting thing is, too, that one of the big features of cervicogenic headache is that it starts in the suboccipital area and then spreads into the head. And that's always been posed as one of the big signs, that it starts as a neck pain and develops into a headache. And that's still valid. But as Zhiqi will tell you in her experience with migraine patients, I'll often say it starts in my neck and then develops into a headache. So it's all about putting the whole picture together. You absolutely can't rely on any single feature, basically.
Interesting.
Yeah.
Yeah, there was that study.
So that's really...
Sorry, Mike.
Go ahead, Zhiqi. Yep.
I was just going to mention, there was also that study that, Gwen, I think you were involved in, that they found that the pain maps that patients were drawing for migraine and cervicogenic headache were exactly the same. A predominance of pain here and here, so very similar across the populations if you only look at pain areas. And neck pain being such a common prodromal symptom, sometimes it's not necessarily pain. Sometimes they describe it more as like a tightness or a stiffness, but some kind of symptom in that cervical spine, especially in the upper cervical region, spreading into the back of the head and then behind the eye is very typical for some patients with migraine. So very similar, very overlapping. Yeah.
Okay.
That's so interesting because it really challenges the traditional physiotherapy thinking. Like we always think if it starts in the neck, it's definitely got to be coming from a cervicogenic cause. And yet there seems to be like this shift in this recent work that the idea that neck pain in migraine, it's not always coming from the neck, even though it seems like it's coming from the neck. So it's not really a cervical problem, but rather more a migraine problem. Is that what you're getting at then, Zhiqi?
Absolutely, Michael.
So we should be really thinking outside the box and thinking that it could be one or the other.
Yes. And the other thinking that we should be challenging as well is the thinking that if you press on something and you reproduce the pain, then that's the cause of the pain, that's the source. And we found that that's not the case, So there's been several studies now by Dean Watson where they push on the upper cervical spine and then it reproduces the headache. But this can be done in any kind of headache, cervicogenic headache, migraine, tension type headache, and even in healthy controls. In some people with no history of headache, if you push on the upper cervical spine, it can refer pain in the head. So just producing the pain alone doesn't necessarily tell us that that's the source of the symptoms. What it tells us is that there's a relationship between the two regions, right? There's probably some kind of sensitization going on. So there's that referral of pain from one region to the other. But how the two regions are connected, what's driving what and what's causing what, that doesn't tell us on its own.
Wow, so interesting. It certainly changes the paradigm that I've had for many years. So thank you for sharing this.
Yeah,
so,
would you like to...
because musculoskeletal disorders, if you're talking about knee pain or something, then typically if you push on something that's painful, you'll be thinking that I've located the source of pain, but that's not necessarily true when it's something in the upper cervical spine. Yeah.
So then how do you sort out, and this is for both of you to answer, when you have a patient, for example, that's presenting with migraine and they also have a component of some neck pain or cervical pain, how do you determine whether the neck is the driver? Because I think as a clinician, I feel like if the neck is the purported driver, then I feel like I have something to offer. If the neck isn't the purported driver, then maybe I feel a little bit less useful in that scenario. But how do you sort this out? And is the neck pain just part of this broader sensitization picture? And what does that actually mean?
Great question, Amy. I might start and then Gwen, you add on? Yeah, I think the first thing is you got to go in with an open mind, right? You just said there, Amy, that sometimes we're keen to help patients and we have confirmation bias. So we think, I'm looking for something in the neck, I'm going to find something. So you must go in with an open mind and think that, okay, the neck pain that this patient is describing, it sounds related to the migraine, but is there something wrong with the neck? It can be either or. And if there was something wrong with the neck, what do I expect to find? If this was just someone complaining about the same kind of neck pain without the migraine, I'll be expecting that if I look at the range of motion, it will probably be limited and directionally limited perhaps to what they were complaining about. Then I will find the same kind of limitation when I do a passive, examination of range of motion. I'll be expecting some kind of muscle impairment that's related to the functional limitation. If they said they couldn't do something like maybe look down for a long time, maybe the cervical extensors could be weak or impaired. So matching up the picture as we do in all our other neck patients, and seeing whether we'll find the same comparable signs that Gwen was talking about to then go, all right, this person has all the impairments that matches up to what they're telling us about the neck pain. This makes me more confident that they actually have neck pain that's coming from the neck. And notice here, I haven't mentioned anything about reproducing pain. And Gwen will probably want to talk about this because, again, the third thing that we would like to challenge clinicians about is that when examining patients with headache, perhaps what we're aiming to do sometimes is not to reproduce any pain. Would you like to talk about that, Gwen?
This is my hobby horse, by the way, because it is so important that your manual examination is non-provocative, and even from the point of to be very, very mindful that your thumbs, if you're doing provocative tests like PAs, posterior anterior glides on the neck, that your actual thumbs aren't hurting the patient, because that is a source of so many false positives that you've really got to think relaxed hands, soft, and feeling for actual joint signs, just not tenderness. Tenderness will be there, whatever sort of headache. If you just push hard enough, it'll be tender. So you can't rely on just tenderness alone. It just emphasises the importance of very, very skilled manual handling, to be sure. And then it's just reinforcing Zhiqi's point about comparability. If they've got that, as I said before, 8 out of 10 headache, but 2 out of 10 joint signs and only mild muscle dysfunction, it's not making sense. And so it's getting that clinical picture throughout the whole of the history taking and understanding what the headache is through to what you're actually finding in your physical examination. I just might add one other thing here, because I'm sure there are a whole lot of people who are upset that we're just concentrating on movement, joint and muscle function. Mm-hmm. They can have other problems as well. Those three are fundamental. So they may have dysfunction in their axioscapular region. And we actually found that in another study that was done in Thailand, that if you had a downwardly rotated scapula, you were more likely to have C1-2 joint dysfunction and headache. So a critical part of treatment of those patients are that you look at axioscapular muscle control. I mean, people may have a forward head posture, but they don't have to have one. You can have a cervicogenic headache and not have a forward head posture. We've also found that about 1 out of 10 cervicogenic headache may have neural tissue mechanosensitivity, but it's only 1. So they may have it, but it's not one of those core components that they must have. So I just wanted to, before I forgot, because I just want people to understand that. I'm not saying that everything else is irrelevant. People will have other sorts of signs, but they must have those core ones, and they must be comparable in magnitude to the headache that the patient's complaining of, if you want to say it's a cervicogenic headache. Otherwise, what you're finding is that they have got a cervical component maybe to a migraine or tension type headache, or they've got a mixed headache, all of those other things can be there.
And then you're suggesting, what I'm hearing, I think, is you're suggesting that we kind of broaden our minds out of this more, this diagnostic cluster and think about things like scapular endurance. And then would you include deep neck flexor endurance and extensor endurance?
Yep, absolutely. You still do a full examination of the cervical region and the axioscapular region, because, if you've got scapular, the interesting thing about that study, by the way, it's by a girl called Wanaprom, is her surname. What she found was that most of the people who had scapular dysfunction that eased when you corrected it, the most common was, in fact, a downwardly rotated scapula. And when you think of the insertion of levator scapulae, which originates from your transverse processes of C1, 2, and 3, you can see the compressive forces if their scapula is hanging on levator scapula. So it's a big provocateur of cervicogenic headaches. So sorry, Amy, this is really good, because I don't want people to understand that you just look at those three things and that's it. You've got to do a comprehensive musculoskeletal examination. It's just in your diagnosis to make it, those three components must be there, in addition to whatever. We haven't talked about sensory motor control either. And dizziness, lightheadedness is very common, and it's common in migraine as well as cervicogenic headache. So they can have problems with proprioception, balance, etc. And just stop me raving if you want to, but in our
keep going, Gwen.
in our cervicogenic headache trial, what we actually showed, now they were very responsive, so we know that a multimodal program of manual therapy, therapeutic exercise, and education is highly efficacious in the long term. But we also looked at those who didn't recover as well, and the outstanding feature was they complained of lightheadedness, unsteadiness, and in that trial we did nothing for sensory motor control. And since, there's been another study where they have looked at adding patients with neck pain, dizziness, etc., where they added sensory motor exercises to the regular motor control manual therapy, and the outcomes were far superior. So it's addressing the dysfunctions that are really there. So it's not that narrow little cluster. There can be, in a cervicogenic, in any neck pain patient, cervicogenic headache or whatever, I'll always look at joint position sense, movement sense, balance, etc. as part of my routine screen, especially if they're complaining of lightheadedness or dizziness.
Yeah, that was going to be my follow-up, is what would you consider some of those seminal sensory motor tests? And it sounds like joint position error and doing a balance assessment, all of those things are really important.
And also eye movement control. You can test that as well. And that was one of the things, because, when my earlier career, I didn't even know the word sensory motor. And so I had never thought of looking at balance and all of that sort of thing in neck pain patients. But once we started, and that was Julia Treleaven, really started looking at sensory motor control. And that was the joy of having a practice as well as being an academic. You go out and try everything on your patients that night. And I was absolutely amazed at how many neck pain patients had very poor balance and things like that. So, yes, it's to emphasise the breadth of. You want to look at the articular system, neuromuscular system, sensory motor system, the whole package.
Yeah.
So what you're getting at then, Gwen, it sounds like, is that there's really an interaction between perhaps some of the local cervical findings and maybe some of the more global systems with that regional interdependence, whether it's in the scapular, thoracic region, and
Absolutely.
maybe even some consideration within central sensitization within, the brain, especially if it's been going on for some time. How does a clinician then differentiate? Like if somebody has had a headache for months on end and they've got a combination of these findings, let's say even some central sensitization, I'm sure that gets challenging for the average clinician to differentiate, whether this is truly migraine-based or cervicogenic-based or a combination thereof.
Zhiqi, do you want...
Zhiqi?
Zhiqi, go first, then I'll have a second go.
I think you still have to come back to the patient interview and very carefully listen to the patient. So often people might come in and say they've had more than 10 years of this headache. And what we want to know is, has this headache changed? What is different about it? And we haven't talked about red flags yet, but that's something we keep in our back of our minds if this is red flag headache. But typically people with migraine, they might have started off earlier, and the migraine symptoms could have been very typical when it first began, and it would match the International Classification of Headache Disorders criteria perfectly. But as time goes on, sometimes it evolves a bit. And a typical story might be someone who say, previously the triggers were very clear. It was menstruation. It was more like a menstrual migraine. But now I don't know what triggers it. Anything might, it just comes on. But when it comes on, it has the same features as my previous migraine. Maybe some things have changed a little bit, but overall it is still migraine, but then now I still have the neck pain. And then it's our job as a clinician to work out in a physical exam whether they have comparable signs of impairments that can fully explain this neck pain. So this, certainly you can have central sensitization happening, but we should still be able to find some comparable signs. The real challenge is doing physical examinations that do not entirely rely just on pain itself. Because if someone's irritable, so just thinking about an acute irritable patient of any disorder that comes to us, if they're that irritable, everything that you do is painful and it's confounded by pain, right? You can't rely on the finding then. So it's doing very skillful examination that doesn't produce the pain to let you know, is this function impaired or is it confounded by pain? And a good one will be the PIVM examination. A PIVM assessment is typically non-provocative as compared to the PAVM assessment. So if the PAVM assessment is showing up lots of pain, but then in your PIVM assessment, you're not finding any true hypomobility, then you might be questioning, is the pain that I reproduce on the PAVMs more sensitization rather than a true articular kind of positive joint sign? So that's what putting the picture together is about when it comes to sensitization. Yeah.
And it sounds like a key takeaway is suggesting that we really should be avoiding provoking symptoms in these kinds of patients. So.
Yeah.
In migraine especially, and I'm embarrassed to say that I've triggered migraine in a few of my patients over the years, and that's why I've learned to be more cautious. And it's because in migraine, the hallmark of migraine is sensitivity. And in some of these patients, we know that the neck is sensitive. And they will tell us that. They say, if I go to the dentist or the hairdressers, my neck is in a certain position, or someone does a massage there, it triggers my migraine. So that it's sensitive. You've got to be extra careful. Then there are the ones their neck pain gets aggravated with anything, right? It's there almost all the time. That they're sensitized. You've got to be careful. You have the ones that don't appear that sensitized, but don't forget that migraine goes through a cycle. So their sensitivity can go up and down. So you might see them at times where they're not sensitive. And then you might see them at times when they're more sensitive. And they may not realize that. And this has happened to me in the past where I've done some kind of manual treatment for someone and they've done really well. They've responded really well. And then the second time they came, I did the same treatment. They responded really well. Third time they came, they didn't look any different to me, but they were clearly in a bit of a prodromal phase and they were starting to get a bit sensitized. I did the same treatment and they ended up having a migraine attack. So you've got to be really careful in monitoring the symptoms as you are going along, because sometimes unwittingly that person might already be, elevated in their sensitization on their migraine trajectory, and you might then trigger a migraine attack. Yeah.
Yeah. Gwen,
so
what would you like to add?
Sorry. I was just like, it's not to say that you never use provocative techniques. You might.
Yeah.
Sometimes it's useful to use them. You just have to be careful of who you use them and monitor carefully.
Yeah. Okay. That's great advice.
Yeah. The only thing I'd add is that we're sort of saying we're making it out to be simple. Have comparable signs or don't. It may take you 2 or 3 times, seeing the patient 2 or 3 times to actually work it out. And it's often good to have a trial treatment and discuss it with the patient that sorry, we're not 100% sure of what's going on and we're going to do this as a trial. And then you've got to rigorously reevaluate, are you really having an effect? And you need to do that over time because as Zhiqi was saying, migraine gets very sort of cyclic and, you can do something one day, but it's got to be maintained if we're going to do something. It can't come back 2 days later. But it can take you 2 or 3 treatments to really try to work it out what's going on.
Yeah, I think that's important. And I think it takes the pressure off of the clinician. I mean, just like if we were treating someone with shoulder pain, we're still orienting ourselves to their body and their expectations and all those things. So I think that's lovely that you're saying that the expectation shouldn't be that you figure it all out in the first session, because that's a lot of pressure, especially for a cyclic condition.
I think that's realistic, even for an experienced clinician, that it sometimes takes you more than one session, let alone a less experienced clinician. So that's wonderful to hear.
Yep, sure.
So in terms of like trying to cater care, we have our clinical practice guidelines, which I like them because I think it gives learners great guidance. And I think it gives even seasoned clinicians great guidance. But what we don't get from practice guidelines are things like individualized care or precision. And so what are some of the features that help you identify, maybe I'll start with Zhiqi this time. What are some of the features that help you identify who might actually benefit from more of a cervical-focused approach for someone that has migraine and that component of neck pain?
I think the first thing is that in the patient interview, the patient is telling me a story that the 2 symptoms are highly interrelated. One seems to aggravate the other and vice versa. So there's there. Sometimes the patient says they're separate and straight away, if I treat the neck, only the neck is going to improve. It's not going to affect the other, like there are 2 different conditions. So if I see that there's a strong relationship in the symptom presentation, then in the physical examination, have we got some significant findings that we can address? If there are very mild findings, you got to think about what else is there in my toolbox, that I could be offering as greater value to this patient. Because as physios, we have other strategies that we can help patients with, not just treating the neck. We can give them very good advice and education. In fact, when we talked to a lot of our patients in the pilot study, the participants told us that despite having migraine for many years, there were still things that they didn't quite understand about their own migraine condition and how to manage it. Things like exercise prescription is wonderful. We know that regular aerobic exercise, physical activity helps. And a physiotherapist is well trained to prescribe that, and in a way that is graded for the patient and helps the patient understand that when you first start exercising, it might trigger mild symptoms, but your body gets used to it, your brain adjusts to it, and you gradually persist. So strategies around lifestyle modification, sleep, stress, that those kinds of things are all very useful as well. So you've got to weigh that up against what I'm finding in the neck, what else is there that this patient is not doing the best, for their migraine, which is going to be of greater value on the first day. And then what else can I add to it, and over a period of time, see which things actually work out to be best.
Yeah, I like that because it sounds like you're integrating a little bit of maybe motivational interviewing or opportunities to think about behavior change based on some of those other lifestyle factors that could be, part of the presentation or part of what's driving the presentation, I suppose. Gwen, what are your thoughts?
I'd agree. The finding out everything about the individual and their lifestyle, et cetera, you can do a lot for them in the education, and things that we see are common sense. Often the patient doesn't see, hasn't occurred to the patient. From the individualization, I think that you've got to let the physical examination guide your treatment approach. Mm-hmm. So, for example, if you found dysfunction in the deep neck flexors and the deep neck extensors, exercise them. If you find the joint signs, mobilize them, and your manual therapy is very effective. If you find sensory motor dysfunction, you've got to treat it. So it depends on what the patient's got. The scapular dysfunction, if they haven't got any, it's a waste of time doing hours and hours of scapular exercise. So it's always to let the physical examination guide you. The the other point I'd just like to say is, and this is a general point, we get fixated on pain, and pain relief and all of that sort of thing. And so in many of the clinical trials, the outcome measure is VASs or whatever. But we've also got to think about rehabilitation, because we are rehabilitation experts. And so there's also evidence that just because the pain goes, it doesn't mean that the muscle function automatically returns or the sensory motor function automatically returns. Yeah, so that I think we've got to change our mindsets a little bit and keep thinking of ourselves as rehabilitation experts. And we've got to rehabilitate the articular system, muscle system, sensory motor system. And in doing that, we will get pain relief, but not have pain relief as our sole focus. I think that's been a bad thing of clinical trials, where there was this all this focus was on patient outcomes of pain, but that is just part of the story. And especially when you know that neck pain and headaches are recurrent disorders. And so the best thing that we can do for the patient is really help them to rehabilitate their musculoskeletal system to the best of their ability and our ability.
Yeah, I think that's lovely to recognize really that change in what we need to be, putting weight in. I think pain is such a small sliver of it. I love that we're using different measures like the PROMIS and talking about function and pain interference and different things like that. I'm going to let Michael kind of carry us home here with a question to kind of wrap up a little bit of this session that I think we would love for both of you to answer in your own way based on your experience and knowledge of the topic.
Thank you, Amy. So my last question to both of you, and love to hear what you have to say on this. In terms of, assumption, what's one assumption about neck pain and headaches that you think clinicians should rethink starting tomorrow? And maybe Zhiqi, I'll invite you, and then I'll invite Gwen. Yeah.
All right.
I've got a feeling we're going to have the same answer here.
We still love to hear from both of you.
Before I talk about the one assumption, I just want to mention we've been talking about neck pain, but don't forget the jaw. So we didn't mention the jaw, but certainly don't forget about that. So the one assumption is neck pain can be just sensitivity. So just by pushing on something and it's painful in the neck and it gives you a headache, doesn't mean that the neck is the source of the pain necessarily. It could be just sensitivity.
Right.
Yeah, and it is the same thing that the presence of neck pain with headache doesn't automatically mean it's a cervical musculoskeletal disorder. I think that's very, very important, because in Zhiqi's work and work that's now nearly completed in tension type headache, cervical musculoskeletal signs in patients with neck pain and tension type headache and migraine, it's only present in 30 to 40%. So 60% of people with migraines or tension type headaches with neck pain, the neck function we found to be normal. So I think it's very, very important that we remember that it doesn't automatically mean that it's a cervical musculoskeletal thing, and that treating it as a cervical musculoskeletal disorder will be the cure. It won't be.
Yeah, I think that's great, because you're helping us to discriminate, a little bit better and make sure that we're at least ready to identify it. So this has been a wonderful just dialogue, and I think we're very appreciative to both of you for all of your insight and all the research that you've done in this area, which, just in the 25, 26 years that I've been practicing, it's amazing to me how much the needle has moved in this area. And I think there's other areas of musculoskeletal pain where we can't say we've seen as much movement, but I think this is one area that I believe a lot of strides have been made. And I'm excited to see what else the two of you, in addition to the other individuals that work in your lab, discover in the next couple of years.
Thank you. I'll echo Amy's comments. So thank you for both of you and giving us some insight.
Okay, thank you so much.
Thanks for listening to Hands On, Hands Off, the official podcast of AAOMPT. Subscribe now so you never miss an episode, and connect with us at aompt.org or at AAOMPT on social. Opinions are those of the guests and not official AAOMPT policy. See you next time.